And that's going to be what we're going to talk about today, I think, is what would the blueprint be? If someone's listening to this and they're like so frustrated, they're getting a 3 to 10% increase in the cost, they're getting complaints, they feel like they're offering less and less every year to their employees, they themselves don't really like their benefits very much, this podcast is for you.
Welcome to Self-Funded with Spencer, sponsored by Pareto Health, ClaimDoc, and PlanSight. Whether we're discussing innovative new healthcare strategies, exposing hidden revenue streams or misaligned incentives, or even just cheering on the next generation of this industry, we promise you that you're going to learn something. So thank you for joining us for another great conversation about the future of healthcare.
I bet the sweetest part of my career, if you will, or at least the upward trajectory of my career on captives, they proactively came to me about this idea of building this role at Pareto. However, I've had so many other people talk about captives, whether directly or indirectly, friends of mine that have built their benefits practice on captives. And I was still a little bit one step removed from understanding the value of it. Now that I get here, I go, my goodness, what a serendipitous opportunity. This is where the market's going.
Yeah.
The small to mid-sized market segment, I was telling you that 1% TAM that we have, there's hundreds of thousands of businesses that could benefit from what we do, and just need to be educated on it.
Yeah. Well, and I would start with the B corporations, the conscious capitalism movement. There's a lot of really smart people there. And conscious healthcare is something I want to say out loud to you.
Okay.
I really believe in conscious healthcare, and what you described in the elevator on the way up here, first of all, is how does healing actually work? It's not from outside your body. And then secondly, is we have to have conscious healthcare in the United States. And that's defined, and one of the major tenets, there are 4 major tenets of that. One of them is all stakeholders have to have a way forward. And right now, primary care, the patient, and the funding source, private, capital, the corporations, they don't have a way forward. And you said that to me at lunch.
They don't.
And so we've got to go from unconscious capitalism, where everybody takes as much as they can, to conscious capitalism.
Yeah, and I love that you call it that. And we've already started, I presume, right, Nathaniel? We're rolling, so we'll keep that.
Oh.
The concept of conscious capitalism, great way to kick this off. I am a capitalist. I really am. But in its purest form, in the way that it was envisioned, right, which is you don't have behind-the-scenes deal-making, you don't have handshake agreements with politicians.
Those are crony capitalism.
That's crony capitalism. That's what I'm saying. That's what I was getting at, is that has perverted the nature of capitalism, and that is something I don't ascribe to. But just because that is happening doesn't mean I want to abandon the system altogether and go to something that's completely inferior to it. We just have to shine the light on those egregious infractions, do our best to stamp those out.
And there's so much right now criticism of venture capital and private equity. Those are mechanisms. Those are funding mechanisms. And it feels to me like we're watching capitalism grow up. And it's what you just said. In its first iteration, it was taking a very bad system where the average person didn't have a chance of succeeding and giving people an opportunity. And when you look at education, food, what they can do for their family, generational, success, it just changed the marketplace. There's nothing like capitalism. But what we've seen now is there are parts where healthcare is crony capitalism. You go to Washington, you pay a bunch of politicians to protect you and to take transparency and fairness out of the equation to protect your turf, which is their fiduciary responsibility, but it can't be allowed to occur. And that's where we've watched crony capitalism come in, and we've watched greed in its purest form overwhelm the system at times. And we've got to find a way to have conscious capitalism that serves every stakeholder, and that means every person.
Yeah. Well, what a great way to start the podcast, Scott. I mean, why don't we introduce you? Okay. But I love this, because what ends up happening sometimes is you'll start a podcast and it's like, hey, welcome. And this one had there's a phrase in the stop loss world, run in, right? There's a run in contract. We had run into the conversation that's actually great, and I'd love to keep that. But why don't we do this real quick, Scott? Why don't you introduce yourself, and then, if you would, position what today's episode is going to be about in very short order.
Yeah, I want to commit to everybody who's listening to this that at the end of this podcast, they will hopefully be excited, a little challenged, and hopefully there are distinctions, things we're going to talk about that own them, that have them thinking about a different new way of building health benefits to add years to the life and life to the years by empowering the people that have their health benefits. And in doing that, they'll see decreased costs and improvement in productivity and presenteeism, and it'll give them an opportunity to have a hiring advantage and a sustainable company, retention advantage.
I love that. And what it's really about is it's undermining this misconception in healthcare that in order to lower costs of healthcare, you have to have worse benefits, which is the way that the industry has been trained over the last couple decades is the only way to lower your premium, right, is to raise that deductible, raise that copay. I am of the notion, and I believe you've proved it, that you can have both of those things simultaneously if the incentives are properly aligned. The structure of the plan is better.
Yep. Yeah. And I would say that kind of, positively primordial attitude that you articulated, where you're trying to shift costs back onto individuals, you're trying to minimize the quote unquote risk for the company is, people spend more time at work than anywhere else in their lives. People will be affected by the culture of work more than the culture of, most other things in their lives. And so flipping that on its head, you actually have the opportunity to be the most influential force in a human being's life, and through your culture, through your opportunities, through your benefits, through the educational, health, literacy things that you do. And when you embrace that, you create a better place to work, a place people want to be at more, and you lower your costs.
Yeah, and what is the number? I think it's somewhere around 165 million people in the United States get their healthcare through their employer, right? So roughly half the population in total. This is a way to scale it. This is the channel that you can scale those outcomes that you and I are talking about.
Yep. Then you asked me, what's the blueprint?
Yeah.
How do you do that? And that's going to be what we're going to talk about today, I think, is what would the blueprint be? If someone's listening to this and they're like so frustrated, they're getting a 3 to 10% increase in the cost, and they're getting complaints. They feel like they're offering less and less every year to their employees. They themselves don't really like their benefits very much. This podcast is for you.
Heck yeah. Well, I love that. That's going to be the clip, Nathan. Get that in the opening. All right, cool. Well, Scott, why don't we go back in your story a little bit, though, because I think you didn't wake up one day and have, this whole thing put together. It's probably been the culmination of a lot of your life's work. So why don't we go back in your story? Well, who are you? Where'd you grow up? What'd you study? All that fun stuff.
So first of all, I'm very proud of the fact that my dad's a family doctor.
Okay.
I'm a family doctor, and my daughter, Blair Thwaites, is a family doctor in Frisco, Texas, right here in River City. I'm looking at the Frisco sign outside the window, and she's actually in Prosper. So we've got 3 generations of family doctors. And it started my dad started in Iowa. He was a farm boy. He was tired of being cold. He decided he wanted to go to medical school so he could get the heck out of Iowa. All my family's preachers, teachers, farmers, and butchers.
Okay. And
he was the first kind of professional. Went to Florida to medical school, and we ended up living my childhood until I was 24, 22, somewhere in there. I ended up living in Florida and loved it. But then when it was time to go to residency, I wanted to go to the residency where it's every other night, every other weekend. I didn't feel when I came out of medical school like I was ready to take the responsibility of a human being's life.
Okay.
UT Southwestern, it was every other night, every other weekend. We had 5 emergency rooms, psychiatry, OBGYN, medicine, surgery, pediatrics. And it was just in the firing line all the time. And so that's where I did my residency.
This was at the infamous Parkland
Hospital.
Yes.
That's right.
If you live in the Texas area or Dallas, at least you know of Parkland for sure.
Yeah. So that's how I got to that point. And when I came out of my training, I'd been the chief resident. I'd been one of the kind of in the top 15% of my class in medical school. And I thought that I was all that in a bag of chips. I mean, I would say, today we're sitting here 45 years later. And the one thing I've done is been brought to my knees and shown how, how pride doesn't have a place in medicine. You need to we're a team. We need to work together, and we need to figure out what we can do to serve those that are in need.
And you mentioned the 5 departments, and I know of Parkland for the trauma unit, right? Or,
right.
The things that happen around crashes and gunshots and things like that.
Yep.
But so those 5 units, were you spending time in each one of them developing skills?
Months, literally in each one. And each one, you'd kind of learn what you need to do. And then you'd go on the wards where you would do on the hospital ward where, that you take care of the people that were admitted from the emergency room, and you'd get to see them with a little more continuity of care. And it was a fantastic experience. And I was going back to Florida, but I met this amazing woman, and I said, honey, would you marry me and move to Florida? And she said, sweetheart, you can marry me, you can move to Florida, but you cannot do both. So I said, yeehaw, let's go buy some boots. And here we are, 4 kids and 35 years later.
That's fantastic. Well, she definitely must have been something, right, to convince you to stick around for Texas for 4 decades. But I imagine life here is not too dissimilar to Florida, outside of the beaches.
Yeah. No. It's been such a gift. Now, you guys call these little things, the fish, like bass. You think it's a real fish.
Yeah.
And coming from Florida, it was like, why are people getting excited about this?
Yeah, you should see the little fish that my kids catch in the pond next to our house. And I live in Prosper, by the way. Right. And I mean, they catch these things that are barely the size of your thumb, and they get so excited about it.
Yeah,
so it's all relative, I suppose. Yeah. But so how did that time at Parkland shape you professionally and guide your career path?
Well, I came out and thought I was all that in a bag of chips. And so I went into practice. It was funny because, back in the old days, you didn't get a gift. Like today, people sign contracts for thousands and thousands of dollars, and they go into practice and they have an income guarantee for 2 years. At the time, I went to Irving Community Hospital, and they said, we'll give you $10,000 to open your practice. And so it was like, okay, I got to get going. And as I told you, I'm from Florida. So I had done a lot of geriatrics. And so I said I went around the community saying, hey, who needs a family doctor? And the answer was the nursing homes don't have primary care. So I went to all the nursing homes and said, hey, I'm new, I'll take care of your people. And within a month, I had 140 patients assigned to me. And then it was just a matter of going to the nursing home and getting them all checked in, figuring out what's going on with them, figuring out how I could help them. And then I called all their children and said, hey, I'm taking care of your parents. If you're in Irving, at 1302 Lane Street, I've got a new practice. It's empty. Really would love to have you come see me. And I know a lot about your family history now, and I can probably be a better doctor. And within 18 months, I had a thriving, full practice.
Well, I was going to say, just thinking from a salesperson perspective, right, that's a really warm lead, getting the children of the grandparents or whoever that you're taking care of, right? And then ultimately knowing that there's an element of trust and credibility that's already been developed. So you were able to establish a pretty successful practice early on, but that was a family medicine practice, correct?
I was like Marcus Wellaby, MD, right? And I got in the morning, went to the hospital, then I went to the practice, then I'd go back to the hospital at lunch and go back to the practice and then swing by there on my way home. And then 1/2 day a week, I went to the nursing homes.
Okay.
So I was taking care of, the full continuum of care. It was birth to earth. It wasn't sperm to worm. I didn't deliver
I've never
babies.
heard either one of those.
Yeah, so I did not deliver babies, but once they were born, I would take care of them.
So birth to earth, I got you.
Yeah, birth to earth. And so, but what really happened, the defining moment in my life was 7 years into practice, 3 of my patients who I had gotten to taking care of 3 generations, right? I was taking care of their spouse, their parents, and the kids. 3 of them died over a summer, and it was from like May to September, and all 3 of them had been in to see me in the last 90 days, and all 3 of them were in their 40s.
Yeah, you tell me that. That's really, really sad.
Yeah, and at the end of that, I could barely get out of bed and go to work. I felt like a fraud. I felt like I didn't know what I was doing. And that strong woman we talked about, she helped me get up and get going every day, or I would not have been able to do that. I looked at becoming a lawyer. I mean,
so you were thinking about leaving medicine altogether?
Oh yeah, I was going to go work for an insurance company. I was going to go work for a lawyer. Kind of a kind of guy goes and testifies to, in defense.
Well, cases. I mean, I can understand at least the trauma of losing people that you felt were under your care, obviously relatively early in their lives, as being in their 40s in quick succession. So I understand that trauma. But did you feel there were things or a thing that you were unable to uncover or do that maybe led to that outcome?
Well, so I went back and looked in their charts. Right, to say, what did I do wrong? What did I miss? It wasn't immediately. It took me a minute to get the courage to go back and do that. And what I found was that that all of them, when they came in to see me, had risk. There were identifiable issues that we could do something about. And in my assessment plan, I had said, high cholesterol, diabetes not well controlled, obesity, and metabolic syndrome. We didn't have that term back then, but that's what it is.
Yeah.
And when I had said to my patient, hey, I need you to take another medicine. I need to start you on this thing called a statin. We've got to work on your tobacco. One woman smoked cigarettes, and we've got to get you off tobacco. They all said, but Dr. Conard, I feel fine. Mm-hmm. And I don't want to take another pill. And I promise you I'll change my lifestyle. I'll quit, kind of idea.
Okay.
And then they died. So the revelation for me was I was chasing symptoms. I needed to chase health risk. And that's the theme for the rest of today. Corporations need to understand the health risk of their employees.
Yeah.
And that's got to be done confidentially. It's got to be done, so that I'm not saying that they need to know the details for every person, but I am saying as a collective whole, they need to understand the health risk, because you can manage health risk. That's a leading indicator. When you manage that, then you end up saving people's lives. You add years to their life and life to their years. If you don't, then you don't succeed. And that's where costs go up, every year, and you have good employees that die or get sick and they aren't there, and productivity goes down, and all of the things that we see going on at unconscious companies that aren't.
And how long were you in practice? We haven't even said the words converging health yet. I think we probably should at least introduce your company, but how long were you in practice before the concept of converging health came to be?
So what happened was, at that moment, we switched as a primary care practice. It's called Tiana Health. Tiana means whole and complete.
Okay.
Physically, emotionally, spiritually, financially, and socially.
Okay.
Because we got really clear about is how healing works is it comes from inside that person, and it is facilitated or undermined by those things. And so when you're caring for a person, and corporations are doing this more and more today, you have to care for the whole person.
Yes.
So we became Tiana. It's an Eritrean word for whole and complete in all those areas, and health. And then we would see people and we would tell them their health risk. And, I'd say, how do you feel? And I want you to feel great. But if I said, how do you feel? And you said, I feel fine, but then I'm looking at your numbers and you're at increased risk. I'd say, frankly, Scarlett, we got work to do. Right?
Yeah.
And this is what's going to happen. This is your possible outcome if we continue down this, and here are the choices we have. And with this choice, this happens, with that choice, that happens, et cetera. And so the converging health today, what we do is we create a digital twin where we take that person, just as a family doctor did at the time, but now we're doing it digitally with data and information we get. And then we ask the question, what's the most likely outcome for this person? And then we start running scenarios against what's possible. Okay. And then we can go to a corporation and say, hey, here's the number of people that are headed down this road, and here's this road and this road. And often what they say is, well, we've got point solutions for all those, but I can't get anybody to participate.
Exactly.
So then it's like, okay, we've got to play the dating game. We've got to get more specific. We've got to get the message so that it moves and inspires that person to engage in a way that they're not engaging right now. And it becomes around health benefit literacy, healthcare system literacy, like where do I go, what do I do, and health literacy, what do I have, why do I take this medicine, what does it mean, what are the implications to me? So you put all those together and you can run the scenarios and you can figure out what's going to serve the company the best, and then you put an advocacy navigation program in place where you get those people to actually.
What is that? Where the name converging came together, right? Okay, now it's I'm putting the puzzles together, my brain and the pieces together right now.
And I guess one other aspect of that is I always have believed that physicians, primary care physicians particularly, are going to work directly with corporations, and we're going to. I believe in conscious healthcare, as we talked about right at the top of the program, but in conscious healthcare, all stakeholders must win, and there is, and we don't want people who don't necessarily belong in that process to get stuck in the middle. So right now you've got insurance companies, PBMs, all these things in the middle between the actual human beings and those funding care, the corporation, and the foundational piece of that, which is primary care. And so converging, those two things are going to converge and they're going to work together.
Well, and so where was, if you will take a step back for a moment so that we can go two steps forward, crystallize what you were solving for in the moment. What was the original name of Converging Health? So it was the name of that company.
So it was Tiana Health.
Tiana, excuse me.
That was the clinic.
Okay, that was the clinic.
So what happened is built the clinic. This is a poignant story that those listening will never be able to forget. Okay. And I say that because people come up to me all the time that have heard it on Stacey Richter's podcast and other people's podcasts. What happened? So what happened is we were very, very successful, and I had to add a new doctor to the practice every 9 months. And so over the next, really from 1996 in the last century to about 2003, 2004, we were adding a new doctor every 9 months. We ended up at 13 clinicians, and you got off the elevator and there was a great big avatar of a guy, like this. And it said, adding years to your life and life to your years by empowering you. And so that was our philosophy. We lifted people up. We looked at them as a whole person and try to create Tiana Health in their life. And we grew. One of the people who were coming to me as a patient's husband was the president of a 182 clinic group in North Texas.
Okay.
And so he makes an appointment with me today, comes in and says, we want to buy everything you've got. And we want you to come be our chief medical and strategy officer. And we want you to create what you've created here in our 182 doctor's offices. So that was cool. I was like, I don't know if I can do that. And I really did have to learn how to be less of a entrepreneur and more of a corporate team player.
Yeah.
But that was okay. That was good. And so we went in there and we did that. And the company grew from 343 doctors to 510. We were I got a budget of $2 million to create the data analytics platform.
Okay.
That was the first time I created it. And we were basically doing health risk on everybody in the system. And then we would have them matched up to a primary care doctor, whoever they were closest to or already had a relationship with, and we would manage risk. Eduardo Sanchez, he's now the chief medical officer for the American Heart Association. At the time, he was at Blue Cross, called me up one day and he's like, Scott, what are you doing? I was like, I'm sorry, Eduardo, I don't understand. He said, you're $17 per member per month less expensive than the other primary care doctors in North Texas, and we have 400,000 patients coming to your offices.
Wow.
So it's $5.4 million a month that was being saved. Now, they were 80%, the model they had, they only had their fully insured was 20%. 80% was, what's the word? I'm going to say ASO.
Well, yeah, it's a form of self-insured.
Right, they were self-insured.
Yeah, they're doing the admin services only.
That's all.
Yeah.
So they didn't get to keep that money, but they were saving that money for their corporations. And he's like, this is great. So he gave us, we got bonuses and all sorts of great stuff from them and really expanded those services. And he gave us a lot of fantastic feedback because we couldn't get full marketplace data at the time. And so Obama comes in and I'm like, okay, the ACA, we can manage outpatient risks. I went to the large hospitals, one of the large hospital systems in Dallas. I said, you got 17 hospitals. We've got 510 doctors. We know how to manage risk and we can grow our footprint dramatically and have more people in the kind of the top of the funnel, keep your, and develop a truly brand presence. And let's go form an ACO. And they were like, wow, that's really unique idea. That's great. Let's do that. Third meeting in, they said, hey, we think we should be in one tax ID and we want to buy you. It's like, oh, crap. Okay. So to make a long story short, they bought us. And a year later, and within 90 days, my 36 staff was gone. They'd been reassigned to hospitals. They'd gone to IT. They'd gone to HR. And I'm literally sitting in my office by myself looking at this bullpen of where these people were. And I went to the chief strategy officer. I was like, dude, what'd you do? And he said, Scott, where do you think the $17 was coming from? He said, we got the names of your doctors and we went back and we looked at the revenue from those doctors over the last 2 years. And it was down $100 million and accelerating. And if we'd allowed you to continue, we could have had to close a hospital. That's how much 500 doctors feeding into our hospitals meant to us. So we had to buy you to shut you down. It's our fiduciary responsibility to protect the health of our hospitals.
Jesus.
And I'm like, are you kidding me?
Yeah.
It was my Pelican Brief moment, right? It was like, this isn't real, this isn't real, this isn't real, da-da-da-da-da-da-da-da. And he's like, and I would never be this honest if I didn't respect you so much, because he believed in the same philosophy that I did. And he thought, when we started dating at the beginning of this, he thought we were going to actually do this. But there was the bean counters, and then there were the people who were looking into the future to a new way of practicing medicine, and they had a political struggle. The bean counter won. He was gone within 18 months because he couldn't work in that environment any more than I could. So at that moment, I left, and I realized that.
What you're describing is the biggest perverse incentive I think that exists in healthcare in the United States altogether is that if you get people healthier, somebody's losing money, and ultimately they don't actually want that to happen. Ultimately, like what happens if we get everybody healthy in the United States tomorrow? Lots of people are going to lose money on the healthcare delivery side or the pharmaceutical side as a result of that. So there's this weird dichotomy that exists in for-profit healthcare, which is where I guess the conscious part of capitalism comes in. is that there's a lot of incentives not to have people healthy in the U.S. And so you were just proving that with your model.
Yeah, and I could go through 5 other examples because once this story, so I had to wait for a while before I could tell the story because I had all sorts of legal restrictions. And then when I started telling what had happened, people have come up to me, and I think all of us in healthcare have experienced the moral crime or the moral injury of seeing the perverse incentives. And people will come up continually and at conferences, I've never seen them before. They'll come and give me a hug and say, man, thank you for telling the story because I was really suffering internally thinking nobody else was dealing with that. And so it's been a big deal just to have people see it. And there's thousands of examples of that moral injury that go on. And I feel terrible for the people who work for these large health systems and who have to give lip service to actually wanting to have people be healthy when in the background they're doing everything they can to keep progress from happening.
Yeah.
That's a terrible, terrible thing. So anyway, enough of that. So so at that moment, I didn't know what to do with my life, but I had just rung the bell twice because I'd sold my company and then we sold the practice I had rolled into. So kind of had a choice of what I want to do in life, but my mission statement's adding years to your life and life to years by empowering you to take control of your health. So at that moment, I just looked around the marketplace. Den Bishop is a good friend of mine. He, at the time, was with Holmes Murphy, and they had this thing called ACAP Health, accountable patient, accountable care, accountable patient. So I became the chief medical officer for both of those, and I had the joy of working with first them, then Eric Bricker and Scott Shainvogel. David Toomey was from Cigna. He was the president of the regional president of Cigna. He and I became kind of really close partners, and we developed what we call clinical care engineering. And that's
clinical care engineering?
Yes. Okay. And that's what Compass incorporated with Eric and Scott. And so it was a great time for empowering employers to do things a different way and to be able to lead their people through the healthcare system a different way. Okay. Wally Goma was right in the middle of that whole mix too. So it was a fantastic time. And my thought, this is a little bit mean, but was, you were worried about taking $100 million out of the hospital? I'll find a way to work with employers, and we'll go take $200 or $300 million out of your hospital, right? Because by having people be healthy and not needing it, and that's really what I've dedicated my life to since that time.
Pareto Health is the largest benefits captive in the United States. With nearly 3,000 captive members, $1.3 billion of stop-loss premium in force, and almost 1 million covered lives, no other benefits captive comes close to Pareto Health's scale. But it's not just about the numbers. Pareto Health is a mission-driven organization, and that mission has 2 distinct parts. Number 1, to make self-insurance simple and more accessible for small to mid-sized employers. And number 2, to arm them with the most powerful cost management tools on the market. So if you're an employer frustrated with your healthcare outcomes, or you're a benefits consultant looking for an alternative to the status quo, it's time to consider Pareto Health. Pareto Health, where employers come to do self-insurance right, to do it easily, and to do it at scale.
Well, so then let's start putting the blueprint together, because I think one of the things that, not frustrating, but doesn't always come out the best when you have conversations that are very highbrow conceptual. As you go, yeah, that sounds great, but what do I do?
Yep.
So I would love to let's start marching or putting together the blueprint. And I've been obsessed with this idea of how do you build the perfect health plan? And so I think a lot of what you've done is sort of crystallize and turn that into a product or a program and a product is how do you build the best possible health plan that's out there? So let's look at the foundation. Let's start building a better blueprint for folks that are listening to this of what they could do in the marketplace tomorrow after they hear this.
And so first of all, I'd say, this is not something you and I talked about earlier, but finding the right broker is really important.
I work with a lot of
great brokers in the United States. Coming to mind, Brian Urich comes to mind, Scott Haas and some of the folks that are at USI. I've worked with people at almost every, at Lockton, at Higginbotham, at Hub. They're just great people out there. And of course, what they're doing right now with Health Rosetta is just so inspiring. So the first thing for me that I do is I find a great broker consultant, and then we go talk to and work as a team, because I'm incomplete without them, and I have the clinical informatics that they need. So step 1 in the blueprint is you got to get the data, and you need intuitive, actionable data to act on.
Okay, so data, where's it coming from? We're third-party administrator, claims data, what else do we need?
Yep, so you want medical claims, pharmacy claims eligibility as a baseline. Okay. You get census if you can out of the HR system. We also take in so Converging Health now in our current form, we take in participation data in the point solutions. We take in biometric data. We take in EMR data because we're now working with advanced primary care clinicians and the DPC type clinicians or the ACOs that are at full risk. We'll take it out of Epic. We'll take it out of Elation and we'll put it into our system. And so so what happens is we create that digital twin that is for every person inside it. And then we run scenarios against them to see what the potential outcomes are. And then we look at them as groups to see what they need. And then we go back to the broker consultants and say, okay, how do you want to do this? Do you want to do it through primary care? Do you want to do it through point solutions? What's the regional availability? And now there's some really exciting just as a little aside, but there's some very, very exciting things going on with the virtual primary care. Okay. And, whether you're, talking any of those that are out there, but we've really been excited by some of the things I've seen with those. So, we work, the broker, you've seen one company, right? You have to look at the regional variability. You have to look at what the resources are that's available, whether they're manufacturing or it's a lawyer, or bankers.
Demographics, right? Average age, all that stuff. Yeah.
And so you look at that and you come up with the strategic plan. And then, so that's one, to get the data. Actionable.
And so it's this unstructured, disparate data sets. Put it in, I guess we never touched on it. It's your own system you developed, right?
Yes,
so there's plenty of great data analytics platforms out there, but you decided a lot of them were looking at lagging indicators. They weren't looking at leading indicators. And so I like that, right? Because it's one thing to tell me was what's happened. It's another thing to tell me what to do. And so a big part of what you're looking for is what to do next, right?
Yep. And we're looking into the future. It's really true. So I had the pleasure when I was working with all these companies and these brokerage firms and things to looking into all the different ones. And they gave you the most beautiful picture of what just happened. And even Blue Cross Blue Shield, Cigna, and United Healthcare, their annual reports are incredibly articulate and incredibly depressing. And when you look at it,
it's all doom and gloom, man.
Yeah. And then they'll be like, oh, we have a new blinky shiny program. It'll save healthcare. Sign up for this. Another, $10 PPM. And and they had the agenda, and I get that. But on the flip side, I found myself exhausted, frustrated, and they never worked. Every year, it just went higher and higher. So you have to look at health risk of the population, and then you have to ask the question: what do you do to reduce the health risk? And that's the leading indicator you have to manage.
Well, what I like about that is you mentioned that you also pull in the point solutions that exist today. And this is a conversation you and I had over coffee, is the fact that a lot of great point solutions out there.
Oh, my
Tons of categories, too. And all of them do something in a channel, or some of them might overlap because they do a few things. But it's hard to put them all together, and it's especially hard to articulate their value to a member so that they actually get used. So you're pulling that in as well and making sense of those point solutions. But ultimately, I think the biggest challenge, or maybe the biggest opportunity, depending on how you look at it, is putting these things all back together to a cohesive package so the member can consume them and use them properly. And so you're doing that today, right? You're adding those elements into the fold, into your playbook or your blueprint that's going forward.
Right. So the way that this started was back in 2015, 16, 17. We would we'd look at the population, we'd look at what they needed, and then we'd show it. Like there was a large eyeglass company here in town, and they had a really fantastic HR lead who had great vision into what could possibly happen. And we'd look at it together and he'd say, okay, what are the problems? Well, we've got cardiometabolic. Let's bring on Naturally Slim, which is now Wonder. And we've got, we need more primary care. So we created incentives around primary care, and musculoskeletal, we needed more help on. So we got a Rosti and got them really involved and so forth and so on. But every time we added a point solution, the participation in all the point solutions went down about 10%. And there was a moment when he was pulling his hair out going, his name was Ryan, and Ryan was pulling his hair out going, this is not working. And so he went to his leadership and they wrote us a check to create a program to actually get people to engage. Okay. And part of the data analytics we talked about, literally, you take the big things, musculoskeletal, cancer, diabetes, vascular, which is like hypertension and all the complications thereof, mental health, mental and behavioral health. Those are the big five. And all companies are going to have a continuum across those. And the people that feel fine but are not that are going to become your catastrophics if you don't intervene with them through the kind of avatars and the thing I talked about with our data analytics. There's a place for those point solutions to be the answer to that person's. There's a place for those point solutions to be the answer to that person's problem, but you've got to connect them. So they said, here's a bowl of money, create a program.
Okay.
So we created the My Personal Health Assistant program.
Okay.
And it only exists for the side of the member. It doesn't practice medicine. So these people don't practice medicine. Each company gets their own person. They get to know. We have one company, they made a life-size cutout of George, and they put George in the break rooms, and then on the back of their cards it says, just call George, and it has his phone number, so that anything that a member needs, they just call George, and George figures it out. And George already has all the data. He knows the things that they need to do to reduce their health risk, and he knows everything there is to know about the plan benefits for that company. So it's a matchmaker, but he's not practicing it. He's getting the point solutions, getting the primary care, getting the system to do what the system is meant to do. And so we put this program together, and long story short, for every high-risk person that engages, it saves $1,500 per year per person.
Okay.
For every low-risk person that engages, it saves $600 per person.
Really?
So the ROI is usually 4 to 1. After 3 years, it goes up to 10 to 1.
Okay.
And but that's because things aren't happening to people, right? So the second, we talked about a blueprint. The first part of the blueprint is data and analytics that are intuitive. The second part of it is, actually the second part we kind of skipped over, and that would be looking at how you're communicating and the design of your plan benefits, and ask yourself a question. If you have a musculoskeletal problem, maybe you've just got diagnosed with cancer, maybe you have heart disease and vascular disease or diabetes or neuropathy or something, and look at your plan benefit guide. Is it going to help that person figure out what they need to do or not?
No.
And if the answer is no, redesign your plan benefit guide and walk people through their health journey and say, this is the way that our plan is constructed. What you and I talked about, and I believe so much, remove barriers.
Yep.
So if they'll stay on the yellow brick road, which is the yellow brick road is right care, right time, right place, right person, right price, and they stay out of the ditch called too much care and the other ditch called not enough care. So our goal is to keep everybody on the yellow brick road, that the financial barriers are minimized. But as soon as they fall into a ditch, too much or not enough, the financial barriers go up dramatically. And they're like, ooh, I got to get back on the road. I got to get back on the road. Mike Adams, who is the CHRO for 7-Eleven, he is the best in the world at that. If you ever can talk to him, he's got it. He's figured this out. And the people keep themselves on the yellow brick road and use the resources. So plan benefit design and communication was the third thing. Then advocacy, navigation, and personalized engagement was the next thing. And then now we're talking about two things, primary care and point solutions. Yeah. And so
that advocacy and navigation, I think that's so crucial. I don't want to skip over it, because when you're developing those avatars, at least the way that you're communicating this to me is that you develop the avatar, then you build the yellow brick road, right? You map the yellow brick road for them, but you're helping them map out the things that they need to do, right? It's one thing to say, well, hey, we think you're at risk for a cardiovascular event in the future.
Yeah.
Okay, what do I do, right? Like, what care do I get? What test do I get? Is there a medicine? Do I need to lose weight? You're helping put that action plan together, which I think is pretty significant.
PlanSight is a complete game changer in the world of insurance brokering. As a broker, you know how time-consuming and error-prone the traditional RFP process can be. But what if I told you there's a better way? PlanSight is the only end-to-end RFP solution on the market made specifically for benefits agencies. It's like having a superpower that gets you an average of 8 to 10 hours back per employer renewal per year. And the best part, PlanSight supports all carriers, all funding types, and all group sizes for over 20 different benefits. If you're ready to make your RFP process faster, more efficient, and more profitable, it's time to call PlanSight. Visit plansight.com now to book a free demo and discover the future of insurance renewals.
Yeah, so in our digital analytics and the avatars that we create and the digital twins, and there are many things that are probably the most important thing. Let's do it that way, is the mindset of the person.
Okay.
and you look at how they're engaging with the healthcare system, how they're engaging with their health, and you see these trends and these personality kind of archetypes start to emerge where it's no, don't look. If you don't look, it won't happen to you kind of things. And then there are other people who are anxious and afraid and they're way overdoing it. And then you've got the whole continuum in between. And so when the data analytics come out of our system, it lists the things that person needs to do. And the job of the personal health assistant is to have a conversation like, Spencer, what's important to you about your health? Tell me about your kids or your wife and where you're at in your life and what is your biggest concern health-wise? And then why would you, so Spencer, we're going to have you go get a 6-foot tube, stuck in parts of your body you don't want. We're going to have needles stuck in your arm. You're going to have to take time away from work to go see a doctor, right? Why would you do that? And Susan Oster, my partner, her big thing is until you know their why, you don't take the conversation any further. When you got their why, then you're ready to start the journey together. And that trusting relationship, trust is the currency of effective intervention, if you will. And then the next thing Susan says is then you got to get to know their emotional state. Are they a place where they could deal and really face new things? And is a change management process even possible in their life? And then now we've got a list from the most important, and we use AI to look at people and different kind of archetypes to see which thing is most important for that person first, second, third. The average high-risk person has 15 things that they could do to reduce their risk. The average low-risk person has 6 to 7
Really?
things.
Okay.
Yes. That's what we find in the corporations that we do all this data. We got about 320,000 people we're doing this for right now.
Wow.
So that's what we find. And so that what happens is when you go to a corporation and you offer this service, usually you put incentives in place initially. The first year, you'll get 30-ish% people, kind of the early adopters and the early majority that will start to engage with you. The second year will get into the 50s, and you can get up to 60%. And but then if there's stronger incentives put in place, you can get up. Susan's best performance is, I think, 92%.
Okay.
And she lives between 75 and 85% for corporations she's been working with.
But that's incredibly high engagement no matter how you slice it.
Well, you have to make it worth their while.
Yeah.
Right? And one of the things that I appreciate so much about the Personal Health Assistant Program is they don't coerce or convince anybody. They just get in a relationship and they offer. And they let the person choose in. And I think you have some strong thoughts about why that's important.
Yeah, and I think it's ultimately, you mentioned the incentives. Incentives is where my head always goes to, because any system that's set up has a certain set of incentives, and people respond to that certain set of incentives. And so if you set up this program, it's one thing to say, hey, I'm going to come to you, and Spencer, we're going to help you figure out this healthcare journey for this year and figure out your why and all those things. The other thing is like, okay, well, you're telling me all these things I need to do. Well, how's the plan structured? Is this all going to cost me a bunch of money?
Right.
Am I going to be out of pocket this? And so then you start to go, well, what incentives do I have to either drive those hesitant adopters or late adopters to adopt the program? But you don't want to punish people for taking back control of their health, right?
Yeah. Well, no. I mean, and again, if you start punishing people, they start to feel coerced, and you get
when even punished in the way that, hey, yes, we want you to be more responsible for your health, but it's going to cost you some money too. Well, that's great if you have the discretionary income for that to be possible. Yeah. Right. So then, how do you structure a plan? Remove those barriers, remove those impediments, so they're actually getting the care.
Exactly. And so it saves the company a ton of money. So people get really concerned. I'll never forget, I got in a conversation with the president of one of the companies that I was the physician executive for. And I was like, you should make chronic medications free of charge. All generics, and then if there's only a brand, it'd cover that. And he's like, oh my God, that's crazy. And we ran the numbers. It was going to cost him $235,000. He's like, oh, that's just crazy. And so we looked at the number of heart attacks, strokes, CHF, chronic congestive heart failure admissions, diabetic ketoacidosis, and so forth. I put all those together. And it was like $4 million. And I'm like, if these people had taken those medicines, we'd have been able to cut that in half. And so he did it, and we did.
Yeah.
And that's the kind of thing that data really can help you appreciate. But I will tell you, Spencer, with what we've found, that if you offer, like, usually $600 is the magic number. If you get incentives of $600 or more, you'll get the early adopters, you'll get the early majority. Start to get, if you really communicate and let them, do peer-to-peer communication, like maybe videotaping somebody had a great experience, sharing that with the team. So it's not, marketing, it's a peer-to-peer kind of movement inside the company. We've seen some nice success. But when you make it a penalty, the same $600. So if you say, hey, if you do this, we'll pay you $600. People are like, yeah, that's great. And they often kind of get busy, and you'll get, again, 50, 60% of them. If you say, now, we're going to charge you $600 if you don't do this, you get a 15 to 20% increase in participation.
Right.
It's the silliest thing. It's the same money, but for some reason, we've had that 3 or 4 times where it's like clicking a switch. So
I think I had Gal Gentry from Healthcare Blue Book on, and she described that as the carrot flavored stick, right? You don't want to punish
kind
people.
Of the frozen carrot.
Yeah, you don't want to punish them, but you don't want to just provide positive incentives. There's a balance of a little bit of threat of punishment, or if you will, a little bit more expenditure than if you don't do it too. And then you get most of the people responding to both of those guardrails. Yeah. But then now on an ongoing basis, right? So let's say you developed my avatar. You developed this blueprint for me, this journey down the yellow brick road throughout the year. What does it look like to continue engaging on an ongoing basis to make sure my healthcare journey is a positive one?
Because it's all about accountability now,
okay.
Right? And there's a partnership that develops, right? So, hey, Spencer, what's most important to you? I really want to make sure that I'm there for my 2 children. And I want to make sure that I see my daughter graduate from college and get married, and I want to be there to be with my grandkids, okay? All right, so we're talking about, we need to get another 35 years out of you, right? Okay, so let's figure out what are the biggest things that could happen to you. And, and I've got a list of them. The PHA's got a list of them right there. So it's like, it's a little bit cheating, but that's okay. And so they're like, well, your cardiovascular health is going to be really, really important. Do you know what your 7 numbers are? And, there's 7 numbers that'll save your life. And do you know those numbers? Oh, no, I don't really know what you're talking about, right? Okay, well, here's the 7 numbers, and I wrote a book called The 7 Numbers That'll Save Your Life. And so, let's go through these, and you need to get the blood work done. Do you have a primary care? No, I don't have a primary care doctor. Can I help you find the best primary care doctor possible in Prosper? Her name's Blair Thornton.
Yeah, I was going to say, I think I know where she lives. Yeah,
exactly. And so, can I make the appointment for you?
Yeah.
And what day works? Thursday mornings work for me. Okay, I'm going to do Thursday morning. So they get the appointment. So then they set an appointment to follow up with you afterwards. What did you think? Did you get the things? Did you have any questions? Oh, I don't really understand the triglyceride thing. I don't know what that means, right? Okay, well, let's do some health literacy around triglycerides, right? And so then it's like, okay, when did the doctor tell you they wanted you to come back? Well, she wants me to come back and get my blood done in 3 months. Okay, let's see. That would be August. And did you make an appointment? No. Okay, can I go ahead and get a Thursday morning appointment in August? And you want to get your blood work done 2 weeks ahead of that time?
Yeah.
Can I get that done? Yeah, okay, sure. All right, I'll be calling you first week in August. I'll go ahead and get your appointment with Dr. Thwaites, and then her office will order the blood work. It's like, cool, yes. And so that's the ongoing. With Wonder or some of these, Vera Health and other cardiometabolic solutions, the PHAs often will text or call that person once a week. How's it going? How's it going? How's it going? How's it going? And with Wonder, we actually had a lot of companies that were using that because I knew it so well. And we had them, on average, they would attend 5 to 6 sessions. If you just left them in the wild, they did 8 to 10 if they had that accountability.
Yeah.
So a lot of it's around which point solution are they going to be in, what's their primary care relationship like. A lot of people, one of the important things that the PHAs find is they aren't willing to talk about mental and behavioral health early. But once you get to know them well, they're like, I'm really struggling, or my husband, he's drinking too much, or, I've got a kid that's really anxious and we don't know what to do. And so a lot of the mental health things start to come out. And so it's really important that companies think that through, because when someone's dealing with a mental health challenge, they won't engage in their physical health. And so you got to get that done. So it is literally a partnership over time to identify the health risk and to lower it.
And then you said a lot of this is built on the foundation of advanced primary care. So real quickly, can you define for the audience what is advanced primary care and why is that the basis for all these things?
I told the story about the misaligned incentives with the hospital, and their fiduciary responsibility is to keep people in their hospital, and the fiduciary responsibility of me as a family doctor is to keep people from getting sick. And so in honoring our fiduciary responsibility, we screw things up. And now we've got the fiduciary responsibility the CAA has in the marketplace, right? So we could go on and on about that. But coming back to your question about how do you find primary care that's aligned with what we want, which is to add years to life and life to the years. And what you find, so in an ideal world, you would put the primary care doctor at risk for total cost of care. And what we know is that if you get a great primary care relationship going, then what you have is the cost is reduced in a population of people 20 to 30%.
Okay.
And that's been proven. Millman did a big study, just a couple of years ago. They're doing another one right now. It's 20 to 30%. And so advanced primary care uses the data we talked about, and they are incentivized the right way. They get a certain amount of money every month to take care of people, and then the company can see, wow, what an amazing benefit this is happening. They can see their total cost of care come down. And I think that's what's going to happen in the United States. The kind of broker consultants that listen to your show, the companies that are in the captives, I want to talk about captives real quick before we're done.
Yeah. I'll indulge you in that conversation.
Thank you.
Trust me.
I appreciate that, Spencer. But they're aligned in the same thing. And what happens is they start supporting and taking great care of their employees and their family members or their patients and their and their families, and the cost of care just starts to drop down. You don't have to have the hospitals, the insurance companies, the specialists all on board. You just have great, properly incented primary care and a great company that's putting the right incentives in place, and the costs all start coming down, and the rest of them, they can take care of themselves.
Yeah.
So we don't have to transform the whole system at once. And that's where I believe that the key to transformation is the companies, it's the HR directors, it's the CFOs who now are liable on CAA, and then it's the CEOs and the C-suite that they need to give their HR people the air cover to do the things they need to do.
Absolutely.
And the finances to invest in doing
that. And I jumped on the DPC bandwagon probably about a little over 2 years ago when I heard Dr. Jeffrey Gold speak at the U-Powered Symposium, so David Contorno and Emma Fox's symposium they put on every year. And it was just like standing room only, people wanted to talk about DPC. And it was this weird phenomenon where and the Q&A wasn't so much a Q&A as everybody in the room just going, yeah, and this is why DPC is great, and this is why DPC is great. And it was just this energy, and I'm going, I need to learn more about this subject. But when you say advanced primary care, obviously there's a little bit of a distinction between that and maybe just a traditional or pure DPC. So what are those? Is it purely the tying to outcomes, or can they kind of coexist, or advanced primary care can utilize a DPC doctor? Or I just want to draw some line in the sand between those two terminologies.
Yeah, so the thing is, I've been involved, I'm a board certified family doctor. I've been that way for 40 years now, 36 years actually. And the thing is that we started off in the fee-for-service model with misaligned incentives. Then the DPC movement, I love them because they basically said to heck with the system. We're not going to do that anymore.
At all. Yeah.
That's right.
Yeah.
When they checked out and had people pay them directly, and on one side they'd have people pay them directly, and then they would take great care of people, but then there was no data flow.
Okay.
And as a population health person, if I don't have data, I can't tell you.
So it goes in a little black box.
It's
basically.
a black box.
Okay.
And so I need the clinicians to participate at least enough. Like one of the things we're doing right now is we'll take the data out of their EMR, so they don't have to spend extra time. We'll suck it into our system, so we know that people are coming in and being seen, and so forth and so on. So advanced primary care, so direct primary care as a movement started off with kind of a, to heck with you, we're doing it on our own. And many of the doctors refuse to participate as a team sport. And they're like, trust me, I'm a doctor, I'm going to take care of you. And I have looked at enough data over enough years, and I've had a heart of service for my patients, and I know it's arrogant and naive.
Okay.
I mean, I hate to be that direct. But and they can really benefit from, the AI and all the other things we get. So to me, advanced primary care is a partnership between the clinical practice where you're giving them data that they can then act on, and it makes them more efficient and effective. And they're giving you back enough data that you can keep track of what's happening to that individual. So that's advanced primary care as opposed to the traditional DPC.
So DPC is almost like a trust me, bro situation. I don't know if you ever heard that term, but so what it sounds like is I know what's best for my patient, and I will deliver on that. But can I prove that I actually improved outcomes? Maybe, maybe not, right? So what you're saying is now we're tying that to something we actually can measure on an ongoing basis to test that thesis that you are actually delivering better outcomes.
And the thing I almost say, the answer to your question is yes, but that way I'd say it. And when I say to the DPC doctors all the time, you're freaking great. You are amazing.
Yeah.
All we're going to do is document it.
Yeah.
Like there's no fear here.
Yeah.
You really do know what's best because you have that personal relationship and you're looking at them as a whole person, not just as, a disease or a condition or a chance to make $135 on a visit.
How did we move so far away from the primary care physician being the true quarterback of healthcare for the average American to what we have today? And now it's almost like we're going back towards it, but like a restructuring or re-engineering what primary care is supposed to look like. Why did we move so far away from that as the foundation, you think?
I think it's a systems issue.
Okay.
I really do. I think we started incenting everybody for anything all the time, regardless of whether it improved the health of a person or not. And so that's where unconscious capitalism comes in, and people, whether it's a specialist or a hospital or an imaging center or a surgery center, the key is to do more to people. And you don't need primary care involved because you're not even worried about the outcome. If you hurt them, it's like, gosh, I'm so sorry. You did sign that consent that informed consent that said this could happen. And that's just a very unconscious way of living life. And so I think what's happening now is we're saying, wait a minute, time out. Let's put the incentives in place. Let's get people working together. And at the end of the day, if you want someone to add years of their life and life to their years, the best way to do that is with a trusting, long-term relationship. And so all of a sudden, primary care becomes the keystone of helping that individual.
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans, and allowing them to create an environment where we ensure that the benefit plans are being charged in a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
And so what about the opposite end of the spectrum, right? Let's talk about the situation where unfortunately somebody does find themselves with a catastrophic event, survives, but finds himself with a big hospital bill, and the plan's now got to manage and parse that. And it's a really big number, right? I think about, you mentioned wanting to talk captives, and maybe this is a good segue into it after I ask my question. But I think about big, unforeseen, unpredictable, if you will, risk, and now that it hits the plan, and now that plan has to absorb it, whether through stop loss or the employer or a combination of those two. The category, though, that I'm trying to articulate, though, is this payment integrity category, which is bill review and bill audits and finding fraud, waste, and abuse in these very large bills, because these hospital systems, like it or not, there's no lifetime maximums. There's potentially unlimited amount of money that you can charge in situations as long as it's quote unquote appropriate and provable. So how does an employer fight against those things? And how does an individual fight against those things? And what can be done to help with the payment integrity side on the other end?
Well, you're asking a doctor a health benefits question.
Yeah.
So you've got a lot of smarter people who could give you a much better
Sure.
answer. But I work with a lot of really smart, wonderful broker consultants. And they find ways to solve it. So Scott Haas, I mentioned him earlier.
Yeah, I know Scott. Yeah.
He's got a program that he takes his companies to, where those larger bills get sent to this claims processing center, where they actually, before they're paid, they pre-adjudicate them and see if it's appropriate or not. Preston Paul McCall, he is another guy who's just amazing.
Yep.
And he's found and brought to the marketplace really a solution where they'll actually go get all the medical bills for those hospitalizations, and they'll just go through the bills to see how do the bills correspond to the clinical scenario of what was going on. So they get the medical records and they get the bills, a
forensic
itemized
audit.
bill, and they go through to see if they match, and they don't 30 to 40% of the time. And so they go back and say, this is fraud. and the hospitals are like, oh, sorry, and
Our
let's
bad.
reduce the bill 30 to 40%, right?
Yeah.
And
Well,
so,
and again, maybe I didn't put you in a position to answer a question that wasn't really necessarily your area of specialty with converging. But you just mentioned a number, 30 to 40%. That is a common repeating theme I hear of 30 to 40% of hospital charges are unnecessary to completely fraudulent to whatever word you want to use, and they are on a spectrum. But that suggests that 30 to 40% of that particular sector of healthcare is unnecessary, that if we could eliminate it, we'd chop off 30 to 40% of spend. And so I touch on that to say, yes, I believe truly in what you're talking about, the advanced primary care foundation of healthcare. On the other side of things, it's costing a ton of money to most employers is that sector right there.
that's right.
Yeah.
And so two quick thoughts. One, the third thought of what I was going to say to you before, the other place of huge fraud and abuse right now is that what a company is paying an insurance company, and what the insurance company says they're paying the doctor, the spread in there is a huge problem. So we've identified a solution that, I say we, the brokers I work with, they've identified a solution where we are having what they pay the doctor and what they're telling the company they're paying the doctor audited. And again, guess what the number is? 30 to 40% difference. And that money, that again is fraud. They're fraudulently misrepresenting what they're paying the doctors to the company, and they give the money back. So anyway, that's the thing. Now, the answer to your question, I'm a proactive guy, right? So we've got a relationship. The person's going through, and they develop a significant problem, whether neuropathy or they can't hear, or they get diagnosed with an advanced cancer like a pancreatic or biliary cancer, a brain cancer, something that we couldn't have anticipated, we couldn't have screened for. Well, Galileo would argue that, but let's not go there right now. And then they're like, where do I go? And the answer to your question is you get them to the best, highest quality clinician as fast as possible.
Okay.
You get them to the best surgeon as fast as possible for musculoskeletal. And you walk them through a pathway of care. Like for musculoskeletal, I shouldn't have said surgery. It's you get them the physical therapy, you get them the myofascial work, you get them the PRP or stem cell possibly if it's appropriate for them, and then they may end up with surgery. Well, you get rid of 70% of surgeries walking through the proper pathway of care. And you get rid of, and then cancer, we know that up to 50% of people either have the wrong tissue diagnosis or they're on the wrong therapeutic plan. So you get them into an advanced cancer program that will have them nowhere to go, right? And then for valvular surgery, you don't go to, there's a 26% mortality rate for community hospitals that do valve replacements. There's a 6% mortality rate at the Cleveland Clinic. I mean, come on.
Wow. Yeah.
And your insurance works just as well there as here.
Yeah.
So the PHAs, they are moving people into that. And at Mayo Clinic, any really complex, unusual case, we get to the Mayo Clinic. They have a very cool program where, quick story, we had a person who went to an eye doctor who'd been blind in one eye since he was 13. And the eye doctor said, we can now do surgery and fix that, and sent him to this doctor with a very difficult to pronounce name in a surgery center that was out of network. The person called up the PHA and said, how much is this going to cost me? And is this doctor any good? Well, the doctor was not, and it was going to cost him a fortune. So the PHA, this is George, he called the Mayo Clinic, where we have a special relationship with them, where he, it's kind of he can call any time, and said, hey, can you do something about this? The person flew to the Mayo Clinic, was seen by the chairman of the department. The residents and fellows and stuff called him in. He said, we can fix this. The person had surgery the next morning, and he flew back to Illinois, where he's from, the next day, seeing out of that eye for the first time since he was 13 years old.
That's incredible.
That's what we have the potential of doing for people in the United States of America today. But that is so rare.
And I suspect actually the cost was in an advantage position as well, because he wasn't out of network, right? At least for him as an individual. I don't know what the cost of plan.
Well, even for the company, the highest quality care is always the least expensive.
I mean, that's what I'm getting at too, right? That is with the misconception that I started this podcast off with, is you can deliver better healthcare or health benefits to employees at a lower cost if you have the proper alignment of incentives. And usually better care is actually cheaper care simultaneously. And most people think those two things can't be true.
It's not that place anywhere else in our lives, so why would it be that way in healthcare?
Yeah.
Right? And so the first thing is, the best way to use the U.S. healthcare system is to not need the U.S. healthcare system. So try to keep people healthy and keep them out of the system. And then B, when you do, guide them through the system well, and you get rid of a lot of those fraud, waste, and abuse things that you talked about. We still have the problem with the TPAs, the way that they're paying bills and things. We got to figure that out. And that's the whole pre-adjudication and making sure they're actually paying people what they tell you they are. But I'll leave that to you and the
well, let's make this sort of brass tacks for the folks, and we'll sort of inching towards the end here. Types of employers. This works for self-funded employers, presumably only, or
I believe that employers are the ones that are going to step up at some point. They're going to get frustrated enough. They're going to step up, and they're going to be the ones that drive the solving of the healthcare system. So yes, every self-funded employer needs to think the way that we're talking about, manage health risk, and you will save a ton.
Well, is there a size range, though, that you guys are effective on?
For us.
For you as a converging, excuse me.
No. The smallest group we work with is kind of 150, 200.
Okay.
But we also, I mentioned Mike Adams. I get to work with 7-Eleven, and it's such a blessing. And they have, they have tens of thousands of people.
Yeah.
And we work with all of them in between. So that's that. And then, but the other thing I want to say out loud is I was really excited when you asked me to come be a part of your podcast because you work with Pareto, and Pareto is an example of a captive company. And my dream is that there'll be that Pareto would put together a captive and say, hey, if you want to be really aggressive about the health risk management, here's a captive. And so we go to all the young YPO and EPO, all the different groups of entrepreneur, young, smaller companies, and get them to sign up for those captives that are going to truly proactively manage risk. And then you can take the small companies. I don't know how small Pareto
we go down to 50 and even under in a lot of circumstances. Yeah.
So 50 and more. Now we've got a collection of people in those. The beautiful thing about those is it truly is, it becomes a camaraderie where people are teaching each other and learning from each other and getting to know each other, and pretty soon they're playing golf and traveling and growing old together, and it's a wonderful way. So a captive is, to me, a magic environment where like-minded people can, even if they're too small to be self-insured, can get together and manage risk effectively.
Well, and the beauty of the captive is it's the vehicle that allows them to be self-insured at that size, but in a way that's stable and predictable over time. That's what I love about the efficiency of it. And I could spend an hour blabbing to you about captives. I honestly could, and I don't mind indulging the conversation. But it's the most effective way to take that little mom and pop company or 50, 60, 70 life company, give them the advantages that a 7-Eleven has in being self-funded, but give them the same size and scale of Fortune 5, Fortune 10 companies in collective size. And the bigger it gets, the more effective it gets as well. So it's not just the financing and the managing the risk, it's what you talked about, which is the community. We have these big member meetings we do every year, and they get bigger and bigger each year. And it's like people are showing up and they want to go see Tom that they met 2 years ago because he happens to work at the same company and he's in HR as well. They're having drinks, they're having lunch together, but what they're really doing is sharing ideas with one another in a truly open way. And I've never seen a phenomenon like this, even when we have broker events. Consultants that are quote unquote competitors are all sitting around tables brainstorming ideas how to make each other better and win more business and keep these clients and convince them of captives, all these things. I've never seen such an open and collaborative environment. And one, I think it's Pareto is very especially good at it, but the captive itself is the way that you actually accomplish that end.
What did you say to me? Something like less than 1% of companies are...
So, I mean, it depends on exactly what you're defining as your parameters of size, but we would guesstimate that we have approximately 1% of the total addressable market in this broad size segment that a captive would be appropriate for. So that's,
Well, what I'd say about the sitting around shooting the bull and really helping each other out, there are enough bad broker consultants out there. They never have to worry if they're, truly caring about their companies and bringing them great ideas. Yeah. They're going to be so busy, they're going to be like three-legged dogs. They're never going to be able to slow down.
That's it. I think the market is moving, and we'll wrap it up, and I want to get your perspective on kind of the big picture of healthcare in a second. But the market is demanding more You know what I mean? From the what they've traditionally been offered, and the sliding across of a renewal and saying, "Please sign this. We did our best." Right? They're moving away from that. And what I love is this movement towards these alternative risk models like captives that allow or facilitate that transition to happen really effectively, so that those companies can enjoy all those same benefits. But it's incumbent upon us to educate the market, to spread the word as widely as possible, just make people even aware that it is possible for them to do.
Right.
And so that's part of what I do with the podcast, obviously, and content and all that stuff, is just make people aware that it's even possible to do. Once that first step is undertaken, then you can start really building a plan and the image that you want.
Right. Well, I wrote the book, Which Door?
Which Door? Yep.
Which give away free anytime, and any broker, consultant, or advisor or corporation that's listening to this that wants it. Scott at Scott Conard is how you reach me, or you can go to converginghealth.com.
Yeah, we'll make you tag in all the posts for sure.
And all it is to do, it's a story. It's less than 100 pages. It's a one airplane read, and the point of it is, it's possible. And in fact, I would go so far as if you're a CEO, CFO, a COO of a corporation, quit tolerating mediocrity. Go get in action, find the right broker consultant that will take you to a new place. Don't give up hope. So many CEOs that I talk to they've just given up the ghost. I can't do it. It's not going to get better. Every year goes up. It's a game. It's a racket. I'm helpless. And I would say to you, that's not true. And because of CAA, and which I'm sure you've discussed on other shows, maybe you can put some links in where they can learn more about that. Because of CAA, which has now made it a fiscal, fiduciary responsibility of the CFO, and the insurance companies can't run and hide anymore. And so we can just get the information, work with them in a partnership, in a conscious capitalist and conscious healthcare sort of way, but don't stop. Now's the time to lean in, not to stand back.
Yeah. I love that, right? And I was going to ask you a follow-up question, but I think that's a beautiful way to finish it, because I think you wrapped it up so nicely. I could not agree more. Quite frankly, I'm really glad we connected, and now that we've actually sat down and spent some time together, I'm even more jazzed about what you do. So I suspect this won't be our last time to sit down together. But Scott, I appreciate you joining. Thanks so much for joining me for lunch. I am going to ask you for a copy of Which Door so I can read it on a plane tomorrow if you're okay with that.
And
I'll test your theory if I can read it in a trip to Denver and back. I suspect I probably can. But if you don't mind, I would love to read that and have something to read on the plane. But Scott, we'll make sure obviously you get tagged in all the posts and everybody gets attention towards Converging Health. Anything else you want to say before we jump?
I'll just tell one last story, and that is that the CEO of a corporation from Tulsa, Oklahoma came to me. He was getting ready to retire, and he said, Scott, my goal was to build this company in the United States to $1 billion. We did that. But the thing that matters the most to me is that working together and understanding the concept of health risk and going to the data, hooking up with primary care, and then offering them the right benefits. We went from 15 heart attacks a year to 2. We went from multiple preventable cancers being diagnosed in stage 3, 4 to literally 0.
Whoa.
The last year he was there. We help people not get inappropriate surgery and actually get maimed by the system, which we know spine surgery 70% of the time now. And he said, that's the greatest accomplishment of my career. Thank you. And I was like, dude, I did not do this. You did. It was your courageousness to do things a different way that led to this. Because trust me, I've got lots of hot air, but it takes a leader like you to make this happen. And then that's what I want to leave the people listening to this with is it's time, and you can make a huge difference.